exactly how this public utility model would work. And under this model, how would communities reinvest any healthcare savings into other arenas like education and housing and public health initiatives? Tell us briefly what exactly, how would this model work exactly?
How it works is that it's housed in the universities, and we have a collaborative group. You start with collaboration, so you have physicians, nurses, social workers, EMTs, the hospital, they all come together, and this group is the one that does the assessment and looks at what the town needs. And because you're aligned with the university, you use best practice. There's not this 17-year gap between them deciding that a drug is not okay and people still using it in practice. So you get to spend the money. I would say that the role of government then becomes to give me information. I want to know in my zip code, please tell me what is sucking up most of my healthcare dollars. What are the top 2 diseases? I would target those diseases with education and prevention. I would use the savings that happen within a year. You should start to see savings, and within 2 years, huge savings. Then you go back to the community and say, what do you want to spend this on? It looks like that we have a lot of homeless people coming to our area, or it looks like drug addiction is becoming a problem, or these are the statistics we have. And then the community owns healthcare, and people start owning their own health. Okay, and we use the many innovative strategies that nurses are already developing all across this country. We look at what best practices. We use AI to create a platform. We already ran a pilot study of this in Spicewood, Texas. We took we put a nurse practitioner and a nurse into a food bank that was open 1 day a week. When people came in, we created 41 care plans. We changed that food bank from a revolving door to an escalator, where we lifted people up. Within 3 weeks, people were returning canned goods. We had thought that most of the people would be coming who would be elderly. We were shocked at the fact that the most people who came were from 29 to 40 years old. We weren't prepared for that. They weren't on Medicare. They weren't on Medicaid. They were hungry. We paid attention to relationships. We focused on relationships. When somebody came to the food bank and they had newborn twins and they were exhausted, we'd take another member of the food bank and pay for them who to clean their house so that people felt valued and had jobs. We wove that community together.